Good evening, everyone. So, we are continuing our lecture series on drugs and we are continuing our series on antifungals for the past 2-3 weeks. We have discussed terbinafine, ketoconazole, and fluconazole, and this week it's chance to discuss ketoconazole. Now, I am discussing azoles, with together because there's such a good overlap between, of course, the mechanism of action is same. There's a good overlap between adverse events. There's a good overlap between usage cases for different types of azoles. So it becomes easier to understand if azoles are together, and that's why we have discussed itraconazole, fluconazole, and ketoconazole together. Now, ketoconazole is a very good drug. It is one of the most widely studied antifungal with a good spectrum of action against nearly all different kinds of fungi. The only issue is that now we don't use it much, and there's a very good reason for that. The FDA has not approved its usage for a variety of fungal infections, predominantly because of two reasons. Number one is significant effect on liver. So it's very hepatotoxic in higher doses, and even in longer duration of treatment with lower doses, it is significantly hepatotoxic. And other is its varied reactions or its adrenal suppression of the suppression of adrenal hormones. And because of these particular side effects, the usage of ketoconazole has dropped over the years. But it's a very good drug against certain fungal species, namely Malassezia furfur, and its use as a topical agent is very popular and very common among dermatologists. And with that in mind, we'll discuss ketoconazole this week with predominant stress on the usage of ketoconazole as a topical agent. And I'll tell you with this video what are the associated adverse events with ketoconazole and why do we not use ketoconazole that commonly as compared to other azoles like itraconazole or fluconazole. Okay, so without further ado, we should start our discussion on ketoconazole in dermatology. Let's move forward. So ketoconazole is an imidazole, and this is one of the only drugs in the class of imidazole. We have previously discussed that classification of azoles include triazoles and imidazole depending on number of nitrogen atoms, and triazoles include fluconazole and itraconazole and other azoles. Imidazole have only one drug class of importance, which is ketoconazole. There's a levo form of ketoconazole, which is levoketoconazole, but ketoconazole is you could say, the most famous imidazole or very well known imidazole, and that's why we just take it as a prototype drug of this class. So, ketoconazole was approved in the year 1981. It's a weak dibasic agent and it requires acid for dissolution and absorption. So, for proper dissolution of ketoconazole, we need an acidic environment because the drug is weakly basic. It needs to, kind of break apart, not exactly break apart, but it should be easily released in the environment for proper absorption. Okay, so with that in mind, we need an acidic environment. Hence, whenever we use ketoconazole in patients who are taking antacids or who have a kind of a higher pH in the stomach, the ketoconazole absorption is not that good. Okay, so we have told you that ketoconazole is most studied antifungal, extensively used antifungal, but over the years, the usage of ketoconazole has decreased because of its adverse event. And initially, ketoconazole was available as 200 milligram tablets, oral tablets. Okay, but nowadays the recommendation of FDA regarding the use of systemic ketoconazole is somewhat restricted to a very narrow niche. Okay, that niche includes maybe post-surgery Cushing, post-surgery for depressing the adrenal function, or in very recalcitrant or difficult to treat cases of tinea cruris and corporis. These are few of the indications for oral ketoconazole. But remember, these are only recalcitrant recalcitrant infections, and we have better drugs like terbinafine, itraconazole, fluconazole for treatment of dermatophyte infections. So nowadays, the oral formulation is not that used. It's majorly used as a 2% cream, or in fact as a 1% shampoo too. And I think the 1% shampoo one is the most common formulation that we use or we are familiar with. Okay, followed by 2% cream. If it's supposed to be given in pediatric age group, the dose ranges to about 3 to 10 milligram per kg per day, and it is used as a form of suspension. Its usage is only approved after the age of 2 years, not less than 2 years. Okay. Now, the pediatric doses range from 3 to 6 milligram normally. You can go as high as 10 milligram per kg per day, depending on the indication of ketoconazole and if it's causing any kind of adverse events. But nowadays, even the pediatric population, we do not use ketoconazole. We have other better antifungal agents. Okay, let's move forward. So, as I've told you, that ketoconazole is a weakly diabasic agent. Okay, it's a weakly diabasic agent, and being a diabasic in character, it requires acid to get dissolved properly and gets absorbed to get absorbed properly. So whenever your patient is taking any kind of medications which will decrease the stomach acid, the absorption will not be good, and that term we call it as achlorhydria, which is decreased gastric acid. Okay, so now decreased gastric acid leads to decreased absorption of ketoconazole, and because of that, the antifungal activity of ketoconazole is decreased. So we must keep that in mind whenever we are prescribing ketoconazole, and I'm talking about oral ketoconazole. We should always ask if the patient is taking any kind of proton pump inhibitors or histamine blockers or aluminum hydroxide salt suspensions, all those things which will decrease gastric acid. Now, Wolverton mentions that ketoconazole absorption can be increased by using acid beverages, and the book mentions non-diet cola as an example of an acid beverage. So you have to take ketoconazole with non-diet cola or some kind of an acidic medium. Whenever I give itraconazole, I advise them to take it with lemon and water, but to each his own. I just want to stress on the fact that we require a certain acidic medium for ketoconazole to get absorbed. Now, ketoconazole undergoes significant hepatic metabolism, very important. It undergoes significant hepatic metabolism, and it also causes liver damage. And because of ketoconazole was removed from the market. Okay, so remember, in patients who have liver damage, we cannot use oral ketoconazole. We should use other antifungal drugs. Okay, most of the azoles are hepatotoxic. We have to be very careful. Fluconazole is a good option in that phase. It does act on the CYP3A4 family of enzymes, and because of that, there is significant interaction between ketoconazole and other classes of drugs. We'll discuss that when we will be discussing drug interactions later in the video. Peak levels are reached in 1 to 2 hours after oral intake. Bioavailability is about 76% of oral ketoconazole, and it can decrease to about 17% of 76% in presence of acid lowering agent. Okay, and it can increase to about 65% of 76% when taken with a cola or a non-diet cola. Protein binding is about 99%. The T half is biphasic. Biphasic means there are two different kind of T halves. For the first 10 hours after intake of ketoconazole, it's 2 hours. The half-life is 2 hours. And after 10 hours, it is 8 hours. Okay. So what we are trying to say is, let me just draw something here. For the first 10 hours, the half-life will be 2 hours. And after that, it will be 8 hours. Okay. So it has a biphasic half-life. Excretion is predominantly through feces, and that is via bile. So remember, if you remember your normal physiology, bile gets secreted into the intestine, and after several steps, it forms a compound known as stercobilin, and this is responsible for the brown color of the feces. And through bile, ketoconazole is excreted, and 57% is found excreted through the feces, and about 13% through urine. So we can see that majority of the excretion is through the GI tract. So ketoconazole becomes a good drug to be used when renal impairment is considered. Okay, when kidney issues are there, it's a good idea to use ketoconazole. For example, last week when we were discussing fluconazole, I told you that fluconazole the dose has to be reduced, while ketoconazole becomes a bit safer option. Let's move forward. Now, this is the same diagram that we had discussed in previous three videos, and as a part of the larger class of azoles. The mechanism of action of ketoconazole is on the cytoplasmic membrane of the fungus, and it acts by blocking the 14-alpha demethylase enzyme, leading to decreased ergosterol synthesis and defective cell membrane synthesis in fungi. Like all azoles, now this is a mechanism of action which is shared by all azoles. The ketoconazole inhibits lanosterol 14-alpha demethylase. This is an CYP group of enzyme. The same, let's see, cytochromes are a group of enzymes which have a heme moiety. Just like hemoglobin, it has a heme moiety, and the heme moiety is the one of the binding sites of ketoconazole. And when ketoconazole binds to heme moiety, it changes the structure, and the enzyme is not able to work properly. And that is the reason why ketoconazole interacts with a lot of cytochrome enzymes in human body, in human cytochrome enzymes, and has significant interactions with the drugs that are either metabolized by cytochrome, or they get neutralized by cytochrome or activated by cytochrome. That is why ketoconazole has such a large drug to drug interaction list. Okay, so coming back to the mechanism of action, it acts by inhibiting lanosterol 14-alpha demethylase, and this leads to accumulation of lanosterol and deficiency of ergosterol, leading to defective fungal cell membrane formation and thus becoming a fungistatic drug. It stops the growth of fungus. So this is the same flowchart that we had discussed. This time we are discussing ketoconazole as a prototype drug of the class imidazole. It inhibits the enzyme 14-alpha demethylase, and demethylase 14-alpha demethylase is responsible for conversion of lanosterol to 14-alpha demethylsterol, and because of ketoconazole this doesn't happen. So there will be the formation of ergosterol would be stopped, and the fungus requires ergosterol for a good cell membrane synthesis and fungal cell replication. When ergosterol is not there, it's not able to multiply, and that is why the ketoconazole acts as a fungistatic agent. Okay, so that's how ketoconazole acts as a fungistatic agent. So increase lanosterol, decrease ergosterol. These are the mechanism of action of ketoconazole as a group of as belonging to the class of azoles. So their action remains same as other drugs. Okay, so in the last 2-3 slides, we discussed how ketoconazole acts as a fungistatic agent, how it helps to inhibit the growth of fungus. But in our daily, not in our dermatological practice, we have acknowledged that ketoconazole has an anti-inflammatory effect also. It's one of the few or one of the earliest azoles to have an anti-inflammatory effect. So the anti-inflammatory effects is majorly because of inhibition of thromboxane. So if you remember one of our previous videos, we were discussing inflammation in somewhat a bit detailed manner, and thromboxane is one of the inflammatory mediators of that. We will not go into details. Maybe in some future video I'll discuss how does inflammation happen. Now, thromboxane inhibition leads to decrease in inflammation. Additionally, the main mechanism of action of inflammation reduction by ketoconazole is through 5-lipoxygenase inhibitor. So, LOX enzyme, these are in short, they are known as LOX. You have lipoxygenases and you have COX enzyme. COX enzyme is cyclooxygenase inhibitor. Okay, sorry, cyclooxygenase enzyme. Now, what ketoconazole does is it inhibits 5-lipoxygenase, and because of that the leukotrienes are not formed, and because of inhibition of leukotrienes or decrease in leukotrienes, the ketoconazole exerts its anti-inflammatory effect. Additionally, Malassezia furfur. Now, Malassezia furfur is a commensal fungi which lives on our skin and is responsible for various fungal disorders like pityriasis versicolor. And in many of the articles, it's mentioned that Malassezia furfur releases pro-inflammatory molecules, which can be, attributed as a mechanism in which Malassezia furfur was implicated in increase of inflammatory disorders. Many of the articles, or even in our clinical scenario, we see seborrheic dermatitis getting aggravated, and we suspect Malassezia furfur to be one of the causative organisms. So the inflammatory molecules that Malassezia furfur releases leads to this kind of immune or inflammatory dysregulation. The action of ketoconazole on Malassezia furfur is very strong. It's one of the very good drugs against Malassezia furfur. So if M furfur is decreased by ketoconazole, the pro-inflammatory molecules secreted by Malassezia furfur is also decreased, thereby further reducing inflammation. Clear? Let's move forward. This is a very good article if you want to read. I'll mention that in the description. It's about the action of ketoconazole in seborrheic dermatitis. It's a good article if you want to know more about in details about the action of ketoconazole in seborrheic dermatitis. You can access the full text and read. Now it has been mentioned in few articles that ketoconazole has a sebostatic effect. That means decrease the sebum. Either it alters the quality of the secretion of sebum or it decreases the secretion of sebum. And it has been mentioned that there is, because of sebostatic, there's increased lipid accumulation in these cells. For example, these are your sebocytes and they have all those vacuoles containing sebum. And under the action of ketoconazole, what happens is they are not able to release. They are not able to release their sebum, and thus it leads to accumulation of lipid. But that is just one theory; it has not been proven properly. So this kind of action has been said that it could be helpful in seborrheic dermatitis, that it reduces the secretion of sebum. So this sebostatic effect of ketoconazole was implicated as a mechanism of action in ketoconazole when we give ketoconazole in seborrheic dermatitis. The action of steroid hormones is very important. Okay, this is one of the, I think, after the antifungal action, this action becomes very important. Ketoconazole has a steroid hormone depressing effect. It leads to cytochrome P450 enzyme inhibition. I told you that it has significant interaction with the cytochrome enzymes, and a lot of steroid hormones synthesis is dependent on these kind of cytochrome enzymes. And when these enzymes are inhibited by ketoconazole, the subsequent steroid hormones are also decreased. So hormones like aldosterone, cortisol, and testosterone, majorly testosterone, gets inhibited by ketoconazole. So much so that high doses of ketoconazole can act as a significant adrenal suppressant. Okay, you can have a significant adrenal suppression because of ketoconazole, leading to clinical side effects. And this was one of those reasons because of which we don't use oral ketoconazole much now. Okay, but its use paradoxically has increased in Cushing's disease or Cushing syndrome. Cushing syndrome because of this particular action. We'll discuss that. I think I have one slide on Cushing syndrome or the action of ketoconazole in Cushing syndrome. So we have learned about different ways of action of ketoconazole. We know how it acts against the fungus. We know how it acts as an anti-inflammatory agent, how it acts as a sebostatic agent, and how it acts as a steroid hormone suppressing agent. Okay, let's discuss a bit about ketoconazole in skin. So it accumulates after oral doses. We give oral doses in the range of 200 milligram a day, and it accumulates after oral doses. And the main mechanism as to how ketoconazole reaches the site of action is through eccrine sweat. Okay, and ketoconazole can be detected within 1 hour of oral intake and stays there till 1 to 2 weeks after discontinuation of drug. So 1 to 2 weeks after stopping the drug, ketoconazole is still seen at the site. Another mechanism is direct diffusion from the so as I've previously also said that you have an epidermis, you have a dermis, and you have a blood vessel deeper into the dermis, and this is ketoconazole molecule. So directly it diffuses and reaches the layers of the epidermis. So that is one more action or one more mechanism through which ketoconazole reaches the site of action. It is detectable in saliva, serum, and ear wax. So all these all these secretions, maybe except saliva. Saliva does have some amount of fats, but serum and ear wax, it is, you could say that nearly all body secretions can show accumulation of ketoconazole. So this is important that all the secretory molecules have ketoconazole. Now ketoconazole is keratophilic like all azoles. We have already discussed that itraconazole, fluconazole, they were also keratophilic. It likes keratin. That is how azoles stay in the skin. So this is just a short bit about pharmacology of ketoconazole and skin. Regarding pharmacology of hair, some of the articles that I read, the ketoconazole molecules were not detected, so it's not used for any kind of hair fungal infections, or in fact for tinea capitis by endothrix organisms. That ketoconazole is not a good drug. It's majorly suited when sebum or seborrheic areas are affected, or you have Malassezia furfur as an implicating organism. So we have discussed the mechanism of action. We have discussed the different kind of pharmacology of ketoconazole in different organ systems like like skin and the seborrheic areas, its action against the inflammatory molecules, its action against Malassezia furfur. In subsequent slides, we'll discuss we'll discuss what are the different uses of itraconazole. Now, what are the different uses of ketoconazole? Now, ketoconazole at the time of its introduction had such a varied usage. A lot of fungal species was sensitive to it, so much so that a lot of ketoconazole was used, and that led to significant side effects, namely hepatotoxicity and adrenal suppression. And because of these two side effects, the ketoconazole drugs were taken out from the market by the FDA. So right now, we rarely use oral ketoconazole. We kind of prefer using topical formulation of ketoconazole so that the systemic side effects are limited. Ketoconazole is a drug of choice for the disease pityriasis versicolor, where the causative organism is Malassezia furfur. So the Malassezia genus of fungi is very susceptible to ketoconazole. There are reports of individual resistances, but it is significantly susceptible to ketoconazole, and that is why whenever this fungus is implicated, ketoconazole becomes a very good drug. It has also been used in recalcitrant tinea corporis or cruris. Now, these are those dermatophyte infections which are not responding to other drugs. So, only in cases of recalcitrant or difficult to treat infections, you should consider oral ketoconazole. Otherwise, it has a lot of side effects. We have better drugs. We should try other modalities before going to ketoconazole. So the usage of ketoconazole for fungal infections, apart from Malassezia group, is not that much. In fact, in our daily practice, we don't use ketoconazole to treat fungal infections per se, only when Malassezia furfur is implicated. Now, the usage of ketoconazole in seborrheic dermatitis was initially thought because of its action against M. furfur. Okay, so M. furfur is a lipophilic commensal fungi. Let me write it again. Lipophilic commensal fungi. Fungi means commensal means it stays normally also on normal skin without causing any harm. Sometimes, because of multiple reasons, it may overgrow and it may lead to release of many compounds, one of which is indole. Malassezia furfur releases a lot of different compounds. You have a lot of different. I'm not able to remember exactly what the compounds were secreted. Maybe I'll mention them in the comment section. But indole is one of the major compound which causes stratum corneum damage. And because of the damage to stratum corneum, there's release of inflammatory mediators, inflammatory cytokines, leading to aggravation of seborrheic dermatitis. So that is how the role of Malassezia furfur is explained in aggravation of seborrheic dermatitis. However, in subsequent articles, this role was found to be equivocal, kind of a controversial role. People have found that in aggravated seborrheic dermatitis, the level of M. furfur does not increase, or when M. furfur is increased, for example, in cases like pityriasis versicolor, you don't see an aggravation of seborrheic dermatitis. So that is how the role of M. furfur in seborrheic dermatitis is controversial. However, when we use ketoconazole in treatment of seborrheic dermatitis, the symptoms may improve independent of M. furfur concentration. For example, let's say you have a patient of seborrheic dermatitis with increased M-furfur. Okay, you give ketoconazole. Let's say M-furfur doesn't decrease, but still you will see improvement in seborrheic dermatitis. The reverse is also true. The concentration of M-furfur will decrease, but seborrheic dermatitis is clinically the same, or in fact may worsen. Now, this kind of observation has led us to believe that action against M-furfur is not the only mechanism of action of ketoconazole in seborrheic dermatitis. And the latest theory is about alteration of fungal and bacterial microbiota. Now, what do we mean by microbiota? Microbiota is some collection of all the microorganisms that are on our skin. And if it contains only bacteria, then bacterial. If it is fungal, then fungal microbiota. And microbiota, the term as a whole, includes all microorganisms. And we have a certain concentration of different microorganisms on our skin. And when that concentration is disturbed, it leads to disease. Okay, so the theory says that because of alteration of microbiota, we have aggravation of seborrheic dermatitis, and ketoconazole tends to shift the alteration to somewhat of a better state, not necessarily normal, but alter it to that an extent that it leads to suppression of inflammatory activity in seborrheic dermatitis. For example, one of the subsections of the theory of alteration of microbiota states that under the action of ketoconazole, biotin producing bacteria are increased. And biotin is necessary for cell proliferation, fatty acid biosynthesis, and to control inflammation, sometimes to aggravate also, but to make sure that inflammation is in a certain range. So that is how biotin producing bacteria becomes important, and ketoconazole increases biotin producing bacteria. It also increases Cutibacterium acne. This is the organism which is found in relation to acne vulgaris or acneiform disorders, and this is also a form of a biotin producing bacteria. So remember that ketoconazole at the end messages that ketoconazole causes alteration of fungal and bacterial microbiota, leading to stabilization of inflammatory activity, and that is how it controls inflammation in seborrheic dermatitis. So this is the article that I have used as bioinformatics-based hypothesis regarding the use of ketoconazole in seborrheic dermatitis. I'll put the link in the description. Just copy paste it and access the full text article, and just read about it. It's a very good theory. Now, this is the diagram that I've taken from the same article, and here we can see ketoconazole. It acts against sebocytes, normalizing the secretion of sebum, thereby decreasing the sebum secretion as a sebostatic agent. The third is that it alters first mechanism is decreasing sebum, second is bacterial microbiota alteration from non-healthy to healthy. Then action on malassezia. By acting on malassezia, it decreases the malassezia organism and thus decreases the pro-inflammatory stimulation by malassezia. Apart from that, we have told you that this brown thing is malassezia furfur. Now this releases of various chemicals like indole, etc., which will lead to stratum corneum damage. When this is taken care by ketoconazole, the stratum corneum damage is also decreased, leading to chances of good repair of stratum corneum and decrease inflammatory activity. Additional effects on biotin and biotin releasing enzymes, and as an anti-inflammatory agent, and as in zinc homeostasis, we require a good amount of zinc for proper functioning of the enzymes that take care of us. So these kind of mechanisms together come and decrease the inflammatory activity in seborrheic dermatitis. So this is another article. This is a different article, not the same article, in which ketoconazole 2% cream was compared with pimecrolimus 1% cream as for control of seborrheic dermatitis. The magenta one is ketoconazole, while the mauve or purple one is pimecrolimus. So it was found that both of these drugs lead to significant reduction in clinical severity scores in seborrheic dermatitis. But when we compared ketoconazole to pimecrolimus, there was no significant difference. So we could say that ketoconazole and pimecrolimus are somewhat equally acting. So the efficacy of ketoconazole to control seborrheic dermatitis was near as same as pimecrolimus. There was no significant difference between these two drugs. So we can say and safely use ketoconazole in seborrheic dermatitis. And remember that ketoconazole is cheaper than pimecrolimus with a different adverse effect profile. So it becomes one more drug to treat seborrheic dermatitis. Clear? So we have discussed a bit in detail about the role of ketoconazole in seborrheic dermatitis. After the use of ketoconazole in seborrheic dermatitis, we come to the use of ketoconazole in androgenetic alopecia. Now, I've told you before when we were discussing the suppression of adrenal enzymes that usage of oral ketoconazole decreases testosterone levels. Okay, so that is one mechanism of action that has been implicated as to how ketoconazole can help in AGA. Other mechanism maybe as an anti-inflammatory effect. There was one good paper in which it was mentioned that AGA can start as an inflammatory focus. Maybe that is one another hypothesis. But there was a study, and I've quoted that study here. So there was a study in which topical ketoconazole was used as a treatment of androgenetic alopecia, and this is the review that I've quoted. So the way it works is that ketoconazole blocks dihydrotestosterone more so as the blockage on 5-lipoxygenase, which is an anti-inflammatory agent. So majorly the action of ketoconazole on AGA is via blocking DHT majorly. Okay. So in this review, it was mentioned that 2% cream and 1% shampoo were the most common formulations which were either used alone or added to minoxidil or finasteride as an adjuvant and was found to be better. The frequency was about twice weekly or daily shampooing, but the review said that there is equivocal effect on hair shaft diameter. Okay, so they found that there was increase in an entity known as pylori index. And what is pylori index? Pylori index is percentage of anagen hair, in a trichogram multiplied by hair shaft diameter at 1.5 centimeter from bulb of the hair. Okay, so you calculate the width from 1.5 centimeter from the bulb, you multiply that with the percentage of anagen hair in trichogram, and you get pylori index. I've never used it. I've heard it once while I was reading the systemic review. It's, I think, only for academic interest. But they found that there was an increase in pylori index, but there was no significant change in the hair shaft diameter. So that is why it was found to have a, you could say, a complementary effect when used with other drugs for AGA like finasteride or minoxidil. The advantage is that ketoconazole topical formulations have minimal side effects, so they can be added to the armamentarium. I usually give ketoconazole shampoos if required for this particular purpose, but that is only as an adjuvant, not the only treatment ever in AGA. Cushing syndrome is another use of ketoconazole because of its steroid suppressing action. The use is still off label, it is not recommended per se, and it has been extensively used in post surgery patients. What do we mean by post surgery? The surgery is transsphenoidal surgery. So, what happens is when you have iatrogenic Cushing's, you might have to remove the connection of pituitary gland so that the stimulation for secretion of steroid hormones is stopped. And what you would do is you go through the sphenoid passageway and cut the pituitary stop. And because of that, the stimulation for steroid hormone synthesis is blocked, and you don't have intense steroid activity. So this is one of the end stage treatment for Cushing syndrome. So whenever, even before getting the surgery done, or in patients who have relapsed after surgery, ketoconazole becomes a very good drug. And a lot of drugs can be used. If you want to know more about it, you can read this article. But ketoconazole, by its action on these cytochrome enzymes and inhibition of cytochrome enzymes, can be used as a treatment for Cushing's disease or Cushing syndrome. Now, in this article, it was mentioned that roughly two-thirds patients had complete control of the steroid hormones when they were given ketoconazole. But 12% of patients had to discontinue the treatment due to adverse events. So you could see from this systemic review that the side effects are very troublesome for at least 1/8 of the patients, 1 out of 8 patients, and but it did lead to good control in 2/3 patients, predominantly acting as a steroid hormone suppressant. That's why ketoconazole higher doses is used for treatment of Cushing's disease. So that's another use for ketoconazole apart from seborrheic dermatitis. Okay, so we have learned the use of ketoconazole in seborrheic dermatitis predominantly. It can be used in the dosages of 200 milligram a day or twice a day for dermatophyte infections which are recalcitrant. Other uses as per FDA includes deep fungal infections like blastomycosis, coccidiomycosis, other infections like leishmaniasis, mycotomas, okay, subcorneal pustular dermatosis. These are all individual isolated case reports, but maybe when you are answering in your viva or writing a short note on action of ketoconazole, you can mention this additional off-label non-FDA approved uses. Okay, so we have learned about the uses of ketoconazole now. Let's move forward. So in the last segment of our presentation, we'll discuss a lot about the adverse effects associated with ketoconazole. These are significant adverse effects, so much so that it leads to discontinuation of drug. The most important side effect is hepatotoxicity, the most important. It has been found to be symptomatic in less number of patients, less than 0.2%, but asymptomatic rises in SGOT and SGPT values were still present. Symptomatic to that extent that it may prove to be fatal, or the patient might require liver transplantation. So the hepatotoxicity or the liver damage by ketoconazole, it's to such an extent that it may require liver transplantation. This hepatotoxic nature was irrespective of doses or duration. That means even low doses at longer duration or high dosage for a shorter duration, both of these are found to be associated with hepatotoxicity, and this liver damage may not be reversible. So even if liver damage, when it sets in, if you stop ketoconazole, liver might not be able to regenerate properly. That is why hepatotoxicity becomes one of the most significant side effect of ketoconazole, and one of the factors why ketoconazole is not used that commonly as an oral drug. Other side effects include QT prolongation. Now, all azoles lead to QT prolongation, leading to arrhythmias, mainly ventricular arrhythmias or Torsades-de-Pointes syndrome. And that is also one of the side effects of ketoconazole, like the azoles before it. Adrenal insufficiency is one of the very significant or very important side effect also, and it occurs above the doses of 400 milligram per day, and it is because of decrease in adrenal corticosteroid. Remember, inhibition of cytochrome enzyme group of enzymes which are responsible for steroid hormone synthesis. When those enzymes are inhibited, it leads to decreased adrenal corticosteroid formation. This kind of adrenal insufficiency effect is seen at higher doses, more than 400 milligram. If the dose increases to more than 800 milligram a day, the serum testosterone levels decrease. The testosterone levels are totally abolished when ketoconazole is used more than 1600 milligram a day. And when that happens, clinically it can present as gynecomastia, impotence, and oligospermia. So this kind of significant testosterone suppressing action has been reported with ketoconazole. Now, adrenal suppressing action have been used for Cushing syndrome. We have already discussed in one slide before. The testosterone suppressing action has been used in treatment of prostate carcinoma. As a treatment of prostate carcinoma, when you need testosterone antagonistic actions. So, ketoconazole high doses have been used as a treatment for prostate cancer because of that. If any overdosage occurs of ketoconazole, the treatment is supportive and symptomatic measures only. In the first 1 hour, you can use activated charcoal to absorb all the ketoconazole from the system. And that is when we are talking about oral overdosage. I don't think so you can overdose on topical formulations, but oral overdosage, you have to manage symptomatically. In the first hour, activated charcoal may help. Other adverse effects include nausea, vomiting, abdominal pain, decreased cell lines like thrombocytopenia, leukopenia, hemolytic anemia. That is why CBC is also important. And skin side effects like pruritus, rash. Very isolated case of SGS has been reported, but these are very, 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 very rare. By very rare, I mean less than about 0.1% skin side effects. Okay. So we have discussed the we have discussed that how ketoconazole interacts with the cytochrome group of enzymes, and because of that, it increases or decreases the blood levels of various drugs. And these are all the drugs. It is not at all an exhaustive list. The list goes on, and these are the major drugs which the product insert of ketoconazole actually contradicts the usage of these drugs with ketoconazole. And these includes benzodiazepines like midazolam, alprazolam, triazolam, and also statins like lovastatin, simvastatin. Now, statins, the levels are increased because of ketoconazole. These are the statins are metabolized by cytochrome enzymes, and when those enzymes are inhibited by ketoconazole, the levels increase, and this can lead to increased chances of statin-induced myopathy. Statin-induced myopathy. So the chances of this side effect may increase. Other drugs like colchicine are also not recommended to be used together. Drugs like methadone, dronedarone, ergot alkaloids. Usage of ergot alkaloids with ketoconazole can lead to ergotism. So it is contraindicated. So these drugs are contraindicated as by the product insert of ketoconazole. So that is why these drugs should not be combined. Clear? So this paragraph I have taken from the product insert of Nizoral, which is the trade name of ketoconazole. So drugs like diphthalate, quinidine, cisapride, pimozide are absolutely contraindicated. They are known to cause QT prolongation. Ketoconazole also causes QT prolongation. This can lead to adverse event in the form of arrhythmias. Okay, and arrhythmias like ventricular tachyarrhythmias and torsades pointes. These are all torsades pointes. These are all implicated with ketoconazole. How to monitor your patient who is taking ketoconazole? LFT at baseline level is very important. Remember, hepatotoxicity is one of the dreaded side effects of ketoconazole. So baseline LFT should be there weekly for 1 month, and then monthly for 6 months, and then as required basis. You have to stop. You have to stop ketoconazole if the OTPT levels are more than 3 times the upper limit. Okay, so when you're repeatedly measuring KFTs, if it reaches to, let's say, less than 2 times the upper limit of OTPT values, you decrease the dose of ketoconazole, you reduce it by half. If it touches or becomes more than 3 times the upper limit, you have to stop ketoconazole. You have to consider any other drug. The liver damage is significant. A baseline ECG is not recommended per se, but it is advisable to rule out any arrhythmogenic action of ketoconazole, and also to repeat it within 1 week of starting therapy. Okay, so that you may rule any kind of arrhythmias that may occur because of ketoconazole. Adrenal and cortisol levels to be used within 1 week. This is only for when you're using oral drug and you plan to use it or you have used it for a long duration. Or a patient who has taken ketoconazole by self medication by ketoconazole for a longer duration. So you need to have adrenal cortisol levels within 1 week when the patient comes. Or if you're giving ketoconazole as a steroid hormone suppressant, like you use in Cushing syndrome, then you need to have these kind of levels in 1 week. So remember, see, LFTs are required, based on ECG is advisable, and adrenal and corticosteroid hormone levels is also advisable. Additional monitoring, you can do CBC, because remember, one of the rare side effects of ketoconazole is decreasing the cell lines like thrombocytopenia, leukopenia, and even hemolytic anemia. So because of these adverse events, you need to have a CBC too. So we have mentioned in the starting of the video that achlorhydria or decreased gastric acid leads to decreased absorption of ketoconazole, and it's preferable to take ketoconazole with non-diet cola so that the pH level is decreased and ketoconazole is absorbed properly. What happens when a patient is already taking antacids? So one thing that you can do is give ketoconazole with an acidic beverage such as non-diet cola. There are medications which are acid neutralizing like aluminum hydroxide and even magnesium hydroxides. So this patient might be taking this kind of gastric stabilizers or syrups that usually come pink in color that patients usually take to neutralize their stomach acids. Patient might be taking either by recommendation by a doctor or by self. So we need to ask that particular history. And if the patient has to take this kind of acid neutralizing medications, they should take this medication either 1 hour before or 2 hours after the intake of ketoconazole so that the drug may get absorbed properly. We have to continuously monitor the antifungal activity. If the activity is not significant, or if the response is not good, we might consider increasing the dose of ketoconazole. And this we are talking about in presence of antacids, in presence of acid neutralizing agents. So you may consider increasing ketoconazole dose, but remember, with increased doses, there are side effects. So be very careful about it. Clear? Let's move forward. The older pregnancy category for ketoconazole is category C. There have not been much studies about the action or the adverse effect on fetus in humans, but in animal studies, it has been shown to cause syndactylia and oligodactylia. That means less number of fingers and conjoint joint fingers in rat population. And these were when doses were very high, let's say about 80 times the higher doses of humans. So it is known to cause this kind of malformations in rat population. It may also affect the development genitalia. Remember that ketoconazole is a steroid hormone suppressant. Steroid hormone suppressant. So it can alter the development of genitalia in the fetus. So that risk is always there. So whenever you have to use ketoconazole in a pregnant female, do not use it. Consider use of any other azole. Okay. It has been shown that it can cause difficult labor. So that is also mentioned. In lactation, it is not recommended because it is secreted in breast milk. There are other antifungal agents which are safer for the baby, so it's better to consider those like terbinafine. Resistance to azole formulations is we have discussed in the detail when we were discussing itraconazole and fluconazole 2 weeks prior. Since ketoconazole is a fungistatic agent, so whenever it is used for a longer duration or at higher doses, it may lead to increased resistance. And there are cross resistances between azoles. We have discussed that before. The mechanism of resistance is majorly by efflux pumps actually, but the other mechanisms are reduced susceptibility of the enzyme. The enzyme is not responsive to the inhibition by ketoconazole. The second is efflux pumps. So efflux pumps is one of the major reason for resistance in Malassezia furfur or even Malassezia genus of fungi. The third is ERG11 gene. Now, ERG11 gene is responsible for encoding the enzyme alpha demethylase, lanosterol alpha demethylase, and because of mutation in the gene, the binding site is not formed correctly, so that the ketoconazole is not able to bind at the binding site. And since ketoconazole is not able to bind, it reduces the binding affinity of the enzyme to ketoconazole. The enzyme is not inhibited, leading to resistance. So this is the action of ERG11 gene. Now I think this is the last slide of our presentation. We'll discuss about just a little bit of newer formulations. If you answer them in the Viva, it's good marks, I hope. And newer formulation, now what I've already told you that oral ketoconazole is now not used. The recent research is more in making the topical agents better. And how you can make topical agents better? By increasing the drug delivery. Okay, so you're now researching. We are now researching on enhancing the drug delivery of topical ketoconazole, and these are the methods by which we can do that. First is nanostructured lipid carriers. So I've told you that the ketoconazole is very lipophilic, it's lipid soluble, weakly diabasic agent. And using nanostructured lipid carriers, it prevents the light degradation of the molecule. So degradation in the presence of light, that is prevented by using nanostructured lipid carriers. Other is copolymeric micelles or microemulsion. It leads to thermodynamic stability and also increase percutaneous permeability or increase through the skin permeability. The third is using liposomes or neosomes. Okay, and it leads to good skin drug retention, that means stays there, and longer duration of action. Now neosomes are just I think they are ionic, some kind of ionic two membrane micelles. I'll read about it in detail, don't worry. So liposomes and nizosomes can be used to increase skin drug retention and also for the longer duration of action. Clear? With that, we may finish this video. It's already long. So Nizoral drug insert is a further recommended reading. You need to read a bit, at least once you need to read about all the drug inserts. They are very good source of information. I've attached few good articles. This tells you about the new theories in action of ketoconazole and seborrheic dermatitis, and this tells the mechanism of action of ketoconazole and seborrheic dermatitis. And this article tells you the usage of ketoconazole in Cushing syndrome. Good articles. I'll just attach this whole thing in the description. Just copy paste and go to the full text. So again, this week we have finished one more drug. We have discussed ketoconazole. Ketoconazole is a drug which is not extensively covered in Wolverton group. So this video I have made from 3-4 different books and 5-6 articles, and it's a good resource to learn about ketoconazole. One of the good and at one point of time one of the most widely used antifungal drug. We do use it as a topical agent now too. We use it maybe the most common antifungal agent in shampoos is ketoconazole. So if you have any other comments, let me know. If you want me to cover topical antifungals like clotrimazole, luliconazole, leberconazole, cetoconazole, or do you want me to cover antifungal agents for systemic mycosis like voriconazole, posaconazole, isavuconazole? And let me know in the comments. If I get significant comments, I might discuss it now, or I can shift the systemic mycosis, anti-systemic mycotic drugs maybe later in the future. Next week we'll meet again and we'll be discussing the drug griseofulvin. That's one of the very important systemic antifungal which is left. And I'll meet you next week. Till then, adios. Bye-bye.